Thank you so much for coming, and you can just start whenever you're ready.
Okay, so let me go back here. Hold on. Okay, so my name is Tiffany. I am an academic breast radiologist, and I'm here to talk to you guys today about what it's like to be a radiologist, of course, with my experience in the academic setting. I also specialize in breast imaging, which I'll talk to you guys a little bit about as well. So let's get started. A few things that I wanted to chat with you guys today about. I'm going to give you a little background about my story and the journey that I took to get to where I'm at today. I'm going to give you a background in radiology as the awesome field that it is. And I'm also going to show you a typical day in my life and give you an introduction to the different types of imaging that we deal with. And lastly, I'll give you some examples of some cases that we see, including the disease processes and the procedures that I do as well. So I am currently an attending physician on faculty at an academic hospital, UCLA. I'm considered junior faculty because I've been doing this for about 2 years and actually graduated from fellowship from this same institution in 2019. So here is kind of my journey to becoming a radiologist with a specialty in breast imaging. I'm actually one of the less common people to have just gone through everything without taking any time off or doing any special programs. And I was actually very surprised about this when I was going through it, because I thought going into med school that most people just went straight through. You go to college and then you go to medical school. But actually, most people in my class had taken time off in between. They actually had some other non-medical career experience outside of medicine. So they actually came to med school feeling very confident about their decision. Obviously, I had a more idealistic idea of what medicine was like, but I'm also lucky that I got in the first time, so it is what it is. And if I hadn't, I would have taken off some time to boost my resume, do some research, do some community work, that sort of thing. One thing I'd like to point out as well too, so as part of radiology, it's something that you obviously match into as a residency, but you have to do this, what we call intern year. It's just 1 year before you get into dedicated radiology training. You can do medicine, you can do surgery, which is what I did, or you can do something called a transitional year, which is a mix of both. I personally really love procedures, part of the reason why I went into breast imaging. So I chose to do a surgery year before going into radiology. And that really helped my technical skills and I think my overall efficiency when dealing with patient care. And I wanted to talk a little about radiology. So this is really an awesome field that pretty much every other specialty depends on, from primary care to neurosurgery. All doctors rely on some sort of medical imaging to help them make decisions for their patients. We aren't covered on a lot of medical shows, and when we are, it's usually a non-radiologist like holding up a picture upside down. But we're really real, and we do a lot of work for patient care. And while many physicians are okay at reading their specialties imaging, such as a neurosurgeon reading brain MRIs or orthopedic surgeons reading knee MRIs, it's always our responsibility to know more than them in order to pick up very subtle findings or very unusual findings, just uncommon sort of pathologies. Radiology is basically reframing everything that you learned in med school in the form of pictures. So this ranges from X-rays to MRI, CT, PET scans, angiograms, mammograms, and that sort of thing. And actually within radiology, there are different specialties, and each of these is actually a fellowship within my field. And I kind of give an example of some common studies that you may have heard of. So for me in particular for breast, mammography is something that only we read. It's a special sort of study, but it's an example of a radiologic study. One difference is that, interventional radiology has now broken off into its different path. When I was training, which is, obviously not that long ago, it was still kind of another fellowship that you could do after diagnostics, but now it's becoming its own pathway. The other cool thing is that you get to really stay on top of the latest technology. So some of the older radiologists are trained only on X-ray and ultrasound, kind of the more old school techniques, but obviously there's CT, there's MRI. So being a radiologist means that you're kind of on the forefront of new medical technology. By the way, all these specialties, these are things that I rotated through as a radiology resident, for months at a time. So technically all radiologists are trained in at least these fields, and then we kind of subspecialize into one or the other. So some myths, some truths about radiology. Um, some maybe think that radiologists are not real doctors because we're not like running down a hallway and like yelling clear. But ironically, we're the only group in medicine that are considered the doctor's doctor. So that means that physicians consult us for our opinions on their patients' imaging. Also, depending on the specialty, such as breast or IR, we also have our own patients. So the myth that we don't see patients is not necessarily true either. We don't do necessarily rounds with clinical teams, so many may forget that we're actually part of that clinical process. But in residency, for instance, we would take call in the emergency room. And when a trauma would come in, we would have to go to the CT scanner and then kind of read through the CT scan from head to foot, yelling out all the abnormalities to the ED physicians and to the trauma surgeons because they need to know what things are broken, what things need to be fixed. And the cool part is that pictures don't lie. So a lot of the things you can't see on the inside, let's say like a kidney laceration, you're not necessarily going to appreciate that just by looking at the patient. So really, we're doing quite a bit for patients. There's also some funny myth that like we don't like to socialize and we're just like, just by ourselves. I mean, we work great hours so that we actually have more time to socialize. So I don't know where that myth comes from. And of course, radiology, as you can imagine, is one of the toughest fields to learn and is difficult to succeed in. Because like I said, we have to know anatomy, we have to know actually normal variants, so things that are totally fine, they just are variants within the normal population, and also how different disease processes appear. So it is kind of a tricky field. Just a general kind of thought about the road to success, which some people may have heard of. So these are traditionally, right, the 4 specialties that offer the best compensation and lifestyle, work-life balance. I just want to let you guys know that radiologists are generally pretty happy, and compensation is, definitely above average. And this is by no means a driving force behind what you should go into if you end up going into medicine and you're trying to figure out what to specialize in. Because at the end of the day, if you hate what you do, no amount of money is going to make you feel better. That being said, the whole compensation aspect is important. I had over $300,000 in loans accumulating from college through fellowship. And it's really not discussed. The financial aspect of what we do is not really discussed among pre-meds or med students, but it does have some practical significance. Me and all my young attending friends can attest to this. So just something to think about. These are just some surveys from Medscape. Also, most importantly, a lot of radiologists, 93% would choose the same specialty. So that's pretty cool. So let's talk about a typical day for me. So breast imaging is a specialized field in radiology dedicated to the diagnosis and management of breast pathologies. We use imaging in the form of mammography, ultrasound, and MRI for evaluation. And we also perform breast-specific interventional procedures under imaging guidance. So this is a picture of me performing an ultrasound-guided biopsy on a patient. Question, why did I choose breast imaging? I feel very fulfilled seeing patients. And my ideal job was to get a mix of imaging and patient care. I love procedures, and maybe that's why I also used to play a lot of video games growing up, but I definitely needed a field where I was going to be working with my hands every day. And from, if anybody is wondering from a practical standpoint if AI is going to affect our field, I always think that the more hands-on procedures that you do, the less affected you're going to be by AI. AI certainly is going to help us in the future by, helping us look at, let's say, very normal mammograms and helping us become more efficient, but it's never going to really replace what we do. Plus, for a robot to do a subtle sort of biopsy or any of the procedures that we do, it's going to take a little bit more time. So something I also considered. What exactly do we do? So we have our own clinics, which is different than other radiology fields. We do spend some time in a dark room because the eye can see contrast better when it's dark as opposed to when it's very bright, so we can see subtleties. But I would estimate that's only about 30% of my day. The majority of my day really is discussing findings that we see with patients. So if somebody's coming in for a study and I find something, I actually end up talking to them and telling them they need a biopsy or whatever step they need. So that's about 40% of my day. And then the other 30% is going to be procedural based. And I'll show you some cases of the things that we do as well. This is an average day that I have. Obviously, sometimes it's better, sometimes it's worse. It's a mix of what we call diagnostic studies, procedures, and screening studies. What I have in the arrows here, this is just like our daily sort of, not requirement, but just what I happen to be reading every single day. We read about 30 to 40 screening mammograms. We kind of just do it in between cases. And we also read breast MRIs, maybe one or two a day. And I'll go over what a diagnostic study is in my next slide. So being in academics versus private practice, I also do a lot of teaching. So I work with residents and fellows every single day, radiology residents and breast imaging fellows specifically. But we also have kind of like guest residents and fellows from other departments as well, like women's imaging, that sort of thing. I also give lectures about every 3 to 4 months. I'm in charge of the resident curriculum actually, and I help think of innovative ways to teach skills and improve education. And on top of that, I'm always looking for things to present at conferences, and I'm working on journal publications as well. This is a picture of me testing out a new synthetic model for residents to learn and practice ultrasound biopsies on. Basically, this is to help teach ultrasound guided procedural skills so that if you're doing it for the first time, or let's say it's your first week, that your first experience is not with a patient with a lot of stress and anxiety in the air. You can have some time to kind of learn your hand-eye coordination on your own. And myself as well as other faculty members are also involved in teaching residents and fellows of that. So who do we see? So our patients are mostly women, generally above 14 years old or so. We see people at the other end of the spectrum too. I've seen 98-year-old patients. And we also see male patients too, maybe one or two a day. Men come to us with lumps and pain. And of course, the biggest concern is that men actually can get breast cancer. It's not a high percentage, it's about 1% of all breast cancers, but it still happens and we still see it, at a pretty frequent rate. And then more commonly, of course, they have other findings that are benign, such as something called gynecomastia, which is benign breast tissue, or lipomas, which are benign fat tumors, both of which can cause a lump. So it's our job to find out basically how suspicious something is. So what exactly happens in our clinic? So we technically divide our patients up into 3 categories, and I'll talk about 2 of them right now, the diagnostic and the screening. So diagnostic patients are those with a specific issue. So they're one of these 3 categories, really. They can have a symptom such as a breast pain or a breast lump, or they could be coming in for a follow-up, which means that we are following up a finding we had seen on a prior study. Like we had seen them before and they're coming back for follow-up to make sure things have not changed. They can also come back for what we call a callback from screening, and I'll kind of go into that as well too. All those patients are going to go under some sort of imaging, whether it's mammogram and or ultrasound. That depends on their age and their finding. What we end up doing is we think and we decide on the management. The patients can either return to screening, which means that we won't see them for another year. We can recommend a follow-up, which would be this group, or we might recommend a biopsy, okay? And those are very difficult conversations that we have to have with patients, but they're very important. Sometimes we might also recommend additional studies such as an MRI. And that is all something that we deal with in our clinic. We actually talk to them about everything because we're such specialists and we know the most about this particular field. The other group of people that we see in our clinic are screening patients. Screening patients are ones that have absolutely no symptoms at all, okay? They meet certain criteria in order to get a screening mammogram, and I'll tell you what that is. But essentially, they have no issues at all. If they have a normal mammogram, they just go back to their yearly screening, the ideal situation. If they have something that's abnormal, then that's when they go into this callback sort of arm, and they come and see us. So at this point, you might be wondering what some breast pathologies even are. Chances are you've obviously heard of breast cancer and maybe cyst and not too much else. So this is just a brief overview of all the things that we deal with. Of course, I can't go through every single one of these things, but it's just to kind of show you all the things that we see and we do. Some things that I do think are relevant for most people is that you can't tell if a mass is benign or malignant based on a physical exam. So something being mobile or squishy or hard, something like that, those aren't super useful adjectives and they don't replace the need for imaging. What you might want to know too is that the most common type of breast cancer is invasive ductal carcinoma, that's IDC. DCIS, or ductal carcinoma in situ, means that the cancer hasn't really broken out of the ducts yet. So it's not going anywhere, but it's still considered to be a breast cancer and it's treated as such. Also, you should know that there are diseases from elsewhere that go to the breast. So obviously the most common type of cancer in the breast is primary breast cancer, means it starts here. But there's also metastatic diseases that go to the breast. So lymphoma, melanoma, lung cancer, and some of the more rare rhabdomyosarcomas can also present maybe even for the first time in the breast. So we do see a lot of different things. So I can't give a general breast radiology talk without talking about screening mammograms and our current guidelines. I'll go very quickly over this. There's different guidelines in the news, but essentially we go by the ACR, or American College of Radiology guidelines, because we're radiologists and we're the ones who see the cancers. So the general premise behind any screening exam, whether it's a colonoscopy or a mammogram, is the same. Like, we want to catch cancers at early stages to prevent morbidity, mortality, and healthcare costs. If a cancer is advanced enough that a patient can feel it, we can obviously still take care of it. But we ideally want to find it when it's small. And therefore, the regular asymptomatic woman in the US with an average breast cancer risk, we recommend yearly mammograms starting at the age of 40. There's not really an end age because it all depends on someone's health. For instance, I've seen very healthy 88-year-olds that if they were to be diagnosed with a breast cancer, they would benefit, from surgery, from chemotherapy. They would be fit enough, basically, to withstand all that. We never want to take away that opportunity for those kinds of patients. I've also included here some statements from the ACR about varying screening recommendations from other organizations, such as the American Cancer Society. The problem is that obviously the longer that you delay mammograms, let's say to even 45 or to 50, you're missing a lot of cancers that present in their 40s, which can be aggressive. That was for average risk women. For high risk women, we recommend earlier and additional imaging. So they actually should be getting mammograms earlier at the age of 30. And they can get alternating yearly breast MRIs starting at 25 to 30. High risk, by the way, if you look here, it means that you will have a calculated lifetime risk of over 20%. You have an over 20% chance, or 20 or over percent chance of developing breast cancer throughout your life. And there's various risk models for this. There's also things like a history of chest radiation. Some people get chest radiation for childhood cancers before the age of 30. Most importantly, all women, especially Black women and Ashkenazi Jewish women, should have their breast cancer risk evaluated by 30. And that's something that primary care doctors and OBGYNs help us with as well. So what happens after a screening mammogram? So out of 100 women who get a screening mammogram, most 90 will be told that their mammograms are normal. Okay, 10 will be asked to return to us for additional mammograms or ultrasound. That's a diagnostic arm. 6, upon additional imaging, will be reassured that everything is normal. 2 will be asked to return in 6 months for follow-up exam, and then 2 will be recommended to have a biopsy. So that's just kind of a general idea of what happens. I want to talk to you a little bit about the different imaging modalities that we have as well. So the first one is a mammogram. The screening mammogram has standard 2 views of each breast, what we call a CC, craniocaudal, or MLO, a medial lateral oblique. And this is our mammogram machine. So your breast would go here. There's a clear paddle, if you can see here. And basically the beam goes from here all the way down, and the patient's sitting in this chair. And I also included some diagrams here, what a CC would look like and the kind of picture that it results in. This is what we end up seeing. And I'll kind of go into that a little bit more here. So to understand what a mammogram even looks like, you should first imagine how we read these. So this is the CC view. The right breast is usually on this side, the left is on this side, but I think it kind of varies. I think in maybe Europe and some other places, they may have it switched, but essentially this is the standard way to read it that I read in my training. The easiest way to imagine what's happening here is to think that you are looking down at your feet, okay? So if you can imagine that, let me take you to this next slide. This is some basic anatomy here. So if you're looking down at your feet on your lateral aspect, which is away from your midline, right? That's going to be where your arms are. So if this is your right breast, on this side should be your right arm. Likewise, if this is your left breast, this should be your left arm. And in the middle is going to be your sternum, right in the center. Of course, your nipple is going to be out here, and you might get a hint of something white back here. That's going to be your pectoralis major muscle, so your chest muscle. One thing I want to point out to you as well already is that what is white is going to be fibroglandular tissue. And what is black or really gray is going to be fat. So everyone looks different on mammogram, but white is tissue, and that's technically what can lead to cancer. Cancer doesn't come from fat. There are masses like lipomas, that's a benign fatty growth. That's going to be black because it comes from fat. So this is kind of how we look at cancers, how we look at density. And I'll go into that as well. This is the other view, the MLO view. This view, as you can see, it includes more breast tissue than the CC view. We can think of it here. So this is your right side, this is your left side. Superior means that this is up top towards your head, okay? So your clavicles, your neck, your head's gonna be all the way up here. And of course, at the opposite end of the picture is gonna be your abdomen, your upper abdomen. Here we can see that pectoralis major muscle much more clearly, all right? This is all behind the breast tissue. And sometimes we can see these little white, globular densities here. These are going to be your axillary lymph nodes. So that's how we can detect actually lymphomas, or when breast cancers go to your lymph nodes. The most common lymph nodes they go to are going to be what we call your axillary lymph nodes, and that's going to be in your armpit. So we actually do get a glimpse of them on a regular screening mammogram. So you may have heard of this term called dense breasts. Clinically speaking, there is no way that you can tell what kind of density your breast has, or what density your patient has. This is a finding that's determined by mammogram, not by clinical exam. And there's not enough correlation between a physical exam and the mammogram itself. It's the ratio between tissue and fat. So how much white you see, how much black you see on your mammogram. As you can see here, the majority of the general population, 80%, is going to fall right in the middle, okay? At the opposite ends, which make up about 20%, we're going to have patients that have a lot more fat than breast tissue, or on the other end, a lot more breast tissue than fat, okay? That's going to be 20% of the population. In general, density is related to genetics, and it's not related to size as one may think, okay? There are a few things that do affect density. So most people when they're younger start off with more tissue. They are more dense. And if they go through hormone replacement, they can also have increased density. Breastfeeding, okay, can also increase your density as well. Likewise, when you get older, you will have decreased density because your tissue actually involutes into fat. And interestingly, when you gain weight, you're gaining fat. So the ratio kind of tips the other way, and you actually become less dense in your breast as well too. Now, why does breast tissue density even matter? So like I said, cancer comes from tissue, not fat. So when it's there, it's going to be white on mammogram, okay? I'm giving you an example of two different patients here. One patient is, on the less dense side. She's definitely got more gray than she has white. If I'm looking for a cancer, which I know is going to be white on mammogram, it's probably going to stand out, right? Because it's a nice contrast between the white cancer and a dark background. But in somebody that's more dense, it's much harder for me to find something like this, okay? And in fact, if you really look closely, this is where that exact same finding is, all right? So somebody who is denser, it's going to be harder for us to find cancers. And more importantly as well, too, they just naturally have more tissue. They're more likely to develop a cancer. They're at a higher risk than somebody who is predominantly fatty. So it's an issue of detection, as well as the fact that people with denser breasts have a higher risk of developing cancer innately. That's why breast tissue density matters. Let's talk a little bit about breast ultrasound. So ultrasound is one of the old school modalities, and it's been around forever. The best part, it has no radiation, and it's great for soft tissue in general on any part of your body, okay? The cons are that it's operator dependent, which means that your technologist or your physician can make a picture look very bad or very good just based on how they're operating it. And it can be limited by certain things like air and calcifications. In our world, ultrasound is the first imaging test for women under 30 presenting with a breast lump or pain. And that's because mammography has radiation, and it's less useful in young people who have dense breast tissue. It's harder to see things, and ultrasound a lot of the times can give us a better look at the breast tissue. And so this all, by the way, is evidence from the American College of Radiology appropriateness criteria. This is a very useful website, and I have included it down here for any specialty, no matter what you're going into, because what this is telling you is, hey, I have a clinical question, let's say, even if it's like vaginal bleeding or chest pain, and I don't know what test to order, what imaging study to order. You go to this website, and there's going to be a ranking of all the different types of imaging and what is going to be the best one for you. It's a rating from 1 to 9. 9 is going to be there's evidence base for it. 1 is don't do it. Basically, don't order it. So in this case, we're looking at a female who is younger than 30. She's coming in with a palpable breast mass. What's the most appropriate imaging study, and that's going to be a breast ultrasound. That's given a rating of 9, and there's no radiation. So a very cool link in case you ever want to know what imaging study to get. I'll talk about breast ultrasound specifically. So in our field, we scan our patient in what we call the supine position. So that means that they're basically on their back. I was taught to remember supine like soup, like you're holding it in your hand, as opposed to prone, which is the opposite, where you're lying on your belly. So when I show you this sort of picture, you can orient yourself by thinking that the top of the picture is the front of the patient where the probe is placed. The bottom is the back of the patient. And we can't actually see the real back, but this is essentially your chest wall. So this is your pectoralis muscle, this is your rib, and this is your lungs all the way back here. We try to avoid needles in this area when we're doing biopsies, obviously, because we don't want to cause what we call a pneumothorax, which is a collapsed lung. It happens when a needle goes into the lung. When we do breast MRIs, which is a very specific subset of what we do, the patient's actually flipped in the opposite position, and this helps extend the breast tissue. This is in contrast to CTs where the patient is laying supine on their back. And that's actually because we just want to pull all that tissue down so we can really evaluate it. So who needs a breast MRI? This is reserved for certain groups of patients, for high-risk patients, where even the smallest thing on a breast MRI we want to be able to detect. And people with, let's say, biopsy-proven cancers, the surgeon is going to take them to the operating room, but they want to see if there's any other areas that are involved. Or patients who've already had surgery and they're looking for any residual disease. Interestingly, we also do implant evaluations for silicone implants. And this is an example of an MRI with silicone implants. And I kind of labeled it so you have an idea of what we're looking at. This is the implant itself, right here and right here. And when I say evaluations, I mean we're looking for ruptures of breast implants. So this is one way we can kind of evaluate that. I'm going to go through a few cases now. The first one is going to be an example of a breast mass. So I'm showing you a right breast mammogram from a 56-year-old. She's feeling a lump here. And it's actually marked by this BB here. The circle's a little bit off, but there's a BB here. And the problem is going to be in the way far back of her breast. As you can see, this density looks so different from the rest of her breast tissue. This is what she's feeling. We do an ultrasound, and this is what we show, an irregular vascular mass. And as you may or may not know, cancers tend to be vascular, and that's how they grow faster than other parts of the body. They recruit blood vessels to give them oxygen, and then they grow at an abnormal rate. So then you develop a tumor. That's kind of the general premise behind a breast cancer. So when we see something like this, we recommend a biopsy. We can do it under ultrasound guidance because we don't just stick things randomly. We need imaging guidance. And the pathology came back as a cancer, an invasive ductal carcinoma. This is a very classic case of that. And just so you know, I want to touch on the idea of masses to start off with. So masses by definition are three-dimensional space-occupying structures. We look at their margins and their shape to determine how suspicious they are. This is going to be more suspicious than this. And that's something that you just learned in radiology. One thing I do want to let you guys know is that masses in the breast are not always bad. So these are technically good masses. A cyst is a mass because it is three-dimensional. It occupies space. Same with a fibroadenoma, which is a completely benign breast tumor. So we recommend that patients have an idea of how their breasts feel at baseline, but we don't recommend specific guidelines on self-breast exams anymore. We don't want to increase any false positives or cause any patient anxiety. So knowing your baseline, like lumpy bumpiness is what I call it, and then making sure that you detect anything that's different from that, and then coming into us, that's the most that you can do for your breast health, especially if you are under 40. So a few more cases here. I just wanted to show another example of a mass that's not bad, not a cancer. This is an 81-year-old female who had a stroke, last year. She's on anticoagulation, meaning she's on a medication that thins her blood to prevent her from developing a stroke again. And she's here with a breast lump that she feels on her left side. As you can see, this is very white here. It looks different from the rest of the tissue. Definitely looks different from the left side. So we look on ultrasound and it's subtle, but because this is a little bit more black, it means that there's more fluid in this area. That means that we suspect that this is not a solid mass, which a cancer is solid. A cancer doesn't come from liquid. What ended up happening is that we gave her some local numbing medication with a needle, kind of like at the dentist's office. And we insert a needle in a syringe and we kind of pull back to see what comes out, if anything. And actually all this red bloody liquid came out. So this is actually a hematoma. This is a collection of blood that formed in this patient's breast, likely because she was on blood thinners. She may have had some sort of what we call micro trauma. Maybe she accidentally slept on her breast wrong. Maybe she, hit herself by accident, something small that usually does not cause this problem in the typical person without anticoagulation. But one of the side effects, or one of the things you have to look out for when you're on anticoagulation, is forming these hematomas from microtrauma. It can happen anywhere in your body. It can happen on your leg, your arm, your belly, wherever. This is just an example of what we see in our clinic. And most of the time, the patient doesn't remember a specific, what we call traumatic event. So it's a micro trauma. Here's an example of a 29-year-old female. She came in with a left breast lump. Her first imaging study she should get, because she's under 30, remember, is an ultrasound. So this is her ultrasound that's targeted right over her lump. And so I want to ask you what this thing is. And we see this quite commonly in a specific group of patients. So this is a thin patient, okay? And what she's feeling is her rib. It's completely normal, but it happens in people who don't have much breast tissue. And I kind of annotated everything here so you can see what I'm looking at. Up here is going to be her skin. Her breast tissue is going to be this whole heterogeneous area, the mixing of gray and white here. That's where we look for masses, cysts, and that sort of thing. Like I said before, this kind of long draping sort of thing in dark gray is your pectoralis muscle. Underneath that is your rib. I would expect another rib at this corner here and another one at this, if you were to scan this way. And of course, your lungs in the back here. The cool thing is that when we're ultrasounding people, we actually can see them breathe a lot of the times, and their lungs are going up and down like this. So it's a very dynamic, real-time sort of study. I want to touch briefly as well on something called calcifications. These are very common in the breast. You may have heard of them. The biggest difference in the breast compared to the rest of the body is that calcifications can be an indicator of breast cancer, okay? They look like bright white spots in the mammogram. And like I said, they can be good or bad. It's our decision as to whether we need to do something about them when we see them. We look at morphology, their shape, as well as their distribution. Some we look at and they look 100% benign. We don't worry about them. Some are very suspicious. They need to be biopsied, and others are in between and can be followed. So I'll give you some examples. And by the way, these are things that you don't feel, okay? They never cause pain. They don't cause lumps. It's something that we see purely on ultrasound, or we see purely on mammogram. Sometimes we see on ultrasound, but it's not reliable enough. So this is a 65-year-old who presents for a screening mammogram. You've seen a few mammograms so far in this PowerPoint. There's all these really bright, like crazy lines that are going everywhere. So what are these things? This is a benign finding. These are vascular calcifications, okay? Something that I would expect in somebody her age at 65. They're curvilinear. They're what we call tram track, meaning they're lining the sides of the blood vessels. And this is a benign finding. And we often see them on both sides, kind of distributed evenly. The interesting thing is that if she was on the younger side, let's say 41, I would have to look and see if she has been diagnosed with diabetes or if she was in renal failure. And sometimes, we're the first person who catches that, because let's say she never wanted to go to a hospital. Let's say she had some symptoms of diabetes or renal failure, but she never wanted to go to the hospital until somebody said, hey, you need to go for your screening mammogram. So we would be the first ones to raise that question. So it's very abnormal to have this degree of calcifications in a younger person. It's still a benign finding. It's not a cancer, but it has clinical significance. Now that in contrast to these calcifications, hopefully you can see the difference. These are very suspicious. There's actually a term for it. We call them fine linear branching. They're in the shape of ducts, which is where the cancer starts in the breast. When we see this, we need to call this person back for additional images, and then we generally will biopsy this area. And the pathology for this came back as DCIS. These are subtle things that I had to learn during my residency. So I don't expect general people to know this at all. I just want to give you an idea of when you hear somebody has breast calcifications, whether to be worried or not. And in essence, what I'm trying to say is that you need a little bit more information. Okay. Let's talk a little bit about breast implants. So there's two general types of breast implants. There's silicone and there's saline. Many patients with implants think that they can't get mammograms because they're afraid that they're going to rupture. Okay, so there's an almost zero chance of rupture. I think there are some cases where this has happened, but I suspect the implants were very old or perhaps even in the process of having micro ruptures to begin with. The reason why I'm so confident about that is because number one, I see implants on mammography every day and everyone's fine from an anecdotal standpoint, but also technologists have special methods to displace the implants during mammography. So obviously the cancer is not going to grow inside the implant because there's no tissue. So we only really care about the real breast tissue. This is an example of a full view implant and the breast tissue. And here's a picture, by the way, if you have never seen a breast implant. And this is a picture with the implant just completely displaced. So all you see is the breast tissue. So essentially, mammography is still very useful in these patients, okay? They should definitely still be getting mammograms. Implants may make it a little harder for biopsies because we obviously don't want to puncture an implant. But at the end of the day, we treat these patients exactly the same. We still want them to come for their mammograms and for their studies. This, by the way, is a very large implant. This is a 760 cc saline implant. There's obviously different sizes. I just want to give you guys an example of what one looks like. Now, when you have implants, the most concerning thing is that you worry if something has ruptured. And interestingly, patients go to their PCPs, OB-GYNs, whoever, worried about implant rupture. And let me tell you a few things. So if you have a saline implant, you actually can tell on physical exam if it's ruptured because one side will just be flat. So if anybody's ever seen Orange is the New Black, there is an episode where somebody gets hit in the breast and their breast completely goes flat, like immediately. That's a saline implant. The saline gets resorbed by the body, so there's no harm, no foul. And this is actually an example of somebody who knows that they have implant rupture on both sides, and they just didn't want to fix it. Didn't matter to them. We can see this on mammogram, but you certainly don't need to get imaging to confirm that. Silicone is different. Silicone is more viscous, it's gooier. So even when it ruptures, you may not see a huge difference from the outside. Silicone is not necessarily bad either. It does get resorbed by the axillary lymph nodes sometimes, and it can stay spilled in the breast. And there are different types of rupture technically for silicone, and we can best see those on MRI. So that's some interesting facts about saline versus silicone implants I don't think a lot of people know. Lastly, I'm going to talk to you about some image-guided procedures that we do. So this is my favorite part. These are the four main categories of things that we do. We do biopsies, which are tissue samplings, and that's when we see something suspicious, but we can't tell for sure if it's a cancer or not. So we go in, we take a few specimens, and we send it to the pathologist, the other doctor, and they look at it under a microscope and they tell us what it is in a few days. All of these biopsies or all these procedures, by the way, are done with local lidocaine. So a patient can drive themselves, they can eat whatever they want that morning. There's no general anesthesia, no sedation, and patients are just completely with it during the procedure itself. We also do something called a pre-surgery localization. That's basically pinpointing a cancer for a surgeon. And I'll go into this a little bit later. And that's because in a procedure called a lumpectomy, where they try to take out the minimum amount of tissue, but the correct amount of cancerous tissue, they need some guidance in getting to that exact area. We also deal with non-cancer issues, breast abscesses, which are basically infected pockets of fluid that can happen, and cyst aspirations as well. For those cysts that are very, very painful to a patient, we can actually go in and just take out some of the fluid. So, and this is our, just an example of like a tray that we use for all of our procedures. This is our biopsy device, most importantly, and we have some lidocaine and a scalpel here as well too. So let me go into an example of an abscess. So this is a 26-year-old who had a left nipple ring and a subareolar red palpable abnormality. She had seen her PCP, her primary care doctor, but it wasn't responding to antibiotics. So she came to us to see if there was anything that was basically there. Now, as you can imagine, as the patient or as the primary care doctor, you're looking at this red area and you don't know if there's a pocket of fluid underneath or not. It feels like it, but you don't have any actual proof because you can't see that fluid. All you see is that redness. So at this point, you're deciding, is this a skin infection called cellulitis, or is there an abscess underneath, in which case we may have to drain it. Abscesses are pockets of fluid that after a certain size, they don't get resorbed by the body, okay? They stay there, they can get worse. And technically an abscess, if untreated, can cause systemic symptoms. They can give you a fever, they can elevate your white count. It can get very, very, very bad. So this patient came to us, and right underneath where her nipple ring used to be was this infected pocket of fluid that measured about 4 centimeters. This is blown up, but 4 centimeters is still pretty substantial. So what we do is that we give some local numbing medication, and we put in a needle and we take out some of that fluid. This is a very similar procedure to the cyst aspiration, by the way, but I have some kind of cool pictures here. So this is a real-time ultrasound of our abscess drainage. This is the needle. This is the abscess. And at the end of the day, this is what ends up coming out. So this is a lot of fluid. This is all purulent fluid. And we know it's purulent or pus-like because it's not clear, so it's infected. And there's also a little bit of blood as well too. That's what's giving this the pink sort of look to it. So this stuff gets sent for culture so that we can more accurately pinpoint what kind of bacteria is growing in here. That way we can really pinpoint the antibiotics and really get things better for this patient. So even right after the procedure, my patient's obviously numb from some lidocaine, but she can feel that things are kind of shrinking down. So because we've decompressed this whole area for her. So that's a pretty cool procedure. Let me talk about pre-surgery needle localization. So some terminology in case you guys don't know. A mastectomy is when a surgeon removes the entire breast. A lumpectomy is when a surgeon removes only the cancer, okay? Depending on how you decide which one a patient needs depends on how big the tumor is, if it's gone anywhere else, meaning other parts of the breast, and also partially the patient's preference as well too. That's kind of also very important. But essentially the goal is to take out minimum tissue, but not leave any cancer behind. That's the general goal. So what we do for the patient, for the surgeon and for the patient, is we pinpoint the area for them the morning of the surgery. If you think about it, the breast is kind of like a globe, like a sphere. So it can be very difficult to find an area if you were just to kind of present the patient to the operating room. So this is an area that was biopsied before. A little metallic device was left here precisely for this purpose. The patient comes to us the morning before the surgery. We give some numbing lidocaine and we place this needle and this wire down to that exact same area. Okay, this wire is the exact same thing as this wire. Then the patient goes to the operating room and the surgeon uses this wire to pinpoint exactly the area that she needs to take out, okay? To double check that everything is taken out, the specimen the surgeon produces is sent actually to us to evaluate as the patient is still in the operating room. We make sure that the cancer is in the specimen as marked by this clip that I said before, and this ensures that the surgeon got the right tissue before she closes the patient up. And this is what it looks like in real life as well. So this is another type of needle that we use. This is the specimen itself, and this is the x-ray of it. Obviously, your breast tissue is not rainbow colored, okay? These are just different dyes that the surgeon uses when they are taking out a specimen, so they know how to reorient things if they need to. Not to place it back, but in case, let's say the clip was very close to the blue edge, she will know, or the surgeon will know, that the blue edge was actually the superior part of the cavity that she had taken out, so that she can go and take more of the superior margin. That's the whole point of these dyes. Each dye is representing a different direction, okay? And our goal, like I said, is to make sure that we can see the cancer and then we can see the marker as well. And that's all I have for you guys today. I hope you guys learned something about radiology in general and maybe about my specific field. And I hope that I was able to show you some cool cases about everything. Let me know if you guys have any questions.
Okay, thank you so much for coming. Your PowerPoint was really informational and overall really
Good.
really
Good. Let's see if I have anything here. You guys have mostly pre-meds, right? Like on this meeting. Yeah, if you guys have any questions about radiology in general, applying to medical school, that sort of thing, you know, obviously things change every single year. So when I took the MCAT, it was on a different scoring system than it is currently. So, and I know that they're taking away like step 1 and that sort of thing in the next year or so as well. But I'm not like super far removed. I mean, I did my fellowship 2 years ago. If you guys have any questions about anything on how to be more competitive, or how do you even know that medicine is the right field for you, things that I wish I knew, feel free to always message me and that sort of thing. I'm seeing some stuff in the chat box here. So what are some things that you can do to better your chances of getting to medical school? So true, academics are the most important, right? Your scores and all that stuff. I think real life experience really helps as well too. You know, I interviewed, last year I interviewed people wanting to come to medical school. And honestly, it's really impressive these days. I don't think I could have gotten in if I applied now. But having like real life medical experience, basically knowing what you're going to get into is really important. Either shadowing, you know, a physician, working as part of like a medical clinic, doing anything in your power to have an idea of what it's like to really be a doctor, I think is important. You don't have to go to like another country and like save, you know, children in impoverished villages, although some people do that as well too. But any effort that shows on your application that you're willing to go and look and see what it's like, as opposed to being like, oh, I seen it on some shows, my parents want me to be a doctor, that sort of thing. I very much value those sort of experiences, and I'm always impressed with people who take the time out of their, you know, their fun college years or even their years afterwards, to really look into that. So that's one thing I think that's useful. How many patients do I see face to face? So I do probably like 3 or 4 biopsies a day. So I definitely see those people face to face. And then I have to talk to patients maybe like 8 in the morning, 8 in the afternoon, something like that. And we split the work with our trainees as well too. So when I was a fellow, I talked to every single patient after running through everything with my attending. Now it's a little bit less. I kind of go in like when I need to, you know, fix a situation or whatever, or if I'm at a site where there's no trainee. But essentially, us as a breast radiologist, we're seeing about like 16 plus at least 3, so maybe like 20 patients a day, I think we're seeing. What made me want to pick this specialty? The procedural part, I think of it. Image guided procedures are so cool, guys. It's like the wave of the future. Obviously being a surgeon is like totally awesome too. I consider that, I was between surgery and radiology for a very long time. And this is kind of like the closest that I can get to surgery from the radiology perspective. But I like the continuity of care. I like that there are patients I may read a screening mammogram for. I may say, hey, I'm a little bit concerned about this one area. I might see them when they come back. I might see them for their biopsy, and then I'll know what that finding was. That's a really great continuity for me, for my peace of mind. I like want closure on things that I was concerned about when I read the studies. Also, my colleagues, both at my training site and where I currently work, are awesome. They're very similar to me. We're all like go-getters who appreciate work-life balance, but also work very hard during the day to make healthcare better for women. That's a very rewarding thing. And not all my colleagues are women, by the way. We do tend to have more females than males in our field, but you know, we do have male colleagues as well too, and they feel the exact same way. I mean, you're caring for all women. You're caring for 50% of the population. That's a pretty cool field to be in. Let's see here. If I find a patient has breast cancer, do I directly deliver that news? So that depends. At my old, I think it's institution dependent. At my training site, if it was bad news, like breast cancer, yes, we would have the patient come in for a consultation, and we would talk to them about what breast cancer is, what it means, and that sort of thing, because we're the ones who do the biopsy. At my current place, we always follow up on all of the pathology. But we actually have sometimes the primary care doctor or their OB-GYN, basically the physician who sent them here for the study in the first place, talk with them about the biopsy. And that is because they are the ones who know everything else that's going on with the patient in the grand scheme of things. Because I'm only going to know them from this one perspective, right? Their primary care, their OB-GYN may know how this new diagnosis is going to fit in the grand scheme of things. So they're the ones who chat with them. Now, there's many times there's something called a high-risk lesion. You may remember that from one of our first slides. High-risk lesions are not breast cancers, but they kind of are treated as such. That can be very confusing for primary care and OB-GYNs or people who are just not in my specialty. So sometimes we do jump in and ensure that those patients are seeing the right people for those studies. So it kind of is institution dependent. But certainly as a trainee, when I had to, learn to give what we call bad news to patients, it's a very difficult, difficult conversation, and different people take the news differently. So it's part of our training to know how to approach that sensitive subject correctly. And that's all I have on here. Any other questions? Well, thank you everyone for joining me for this talk. I hope you guys have a great day. Again, if you have any questions, feel free to always message me.
Thank you.
Thanks.
Thank you.